We will now start the presidential debates. Dr. Melvin has been flushed out of hiding. Thank you so much for gracing us with your presence. So we're going to set the ground rules here. We will be following Queensberry rules with a few modifications made for the US combatants. There will be no hitting below the belt. There will be no derogatory comments regarding the opponent's hometown or their institution. That will be a demerit of 1 point each. Any derogatory comments about their sports team, that's a demerit of 2 points. And clean knockouts are acceptable. Thank you.
Thank you. By the way, that is Dr. Young-Fadek, who is one of our program co-chairs. My name is Jeff Marks, one of the other co-chairs. And this is the presidential debate, the great presidential debates of 2014. I'm going to list our first two combatants, and then we'll come to the next two combatants. Scott Melvin, who many of you know because he is our immediate past president, I guess before today's talk. He was our president from 2012 to 2013. He is presently the chief of the Division of Surgery at Montefiore. He's a professor of surgery and at the Albert Einstein College of Medicine. And one thing to understand is that he had been previously at The Ohio State University prior to this. His combatant will be Dr. David Rattner, who was our president from 2004 to 2005, the chief of the Division of GI and General Surgery at the Mass General Hospital. And as we say it in Ohio, he was from that state up north when he was growing up. Our first topic, and both topics are wonderfully controversial, is be it resolved that it is time to declare the death of notes. We have Dr. Scott Melvin for the pro, Dr. Rattner for the con, and then Dr. Rattner will go next with a rebuttal, followed by Dr. Melvin. Before we have them come up, I would like to take a show of hands. Again, reading this again. Be it resolved that it is time to declare the death of notes. How many people in the room at this point in time would say, yes, we need to declare the death of notes? Want to get a show of hands? Okay, I see Melvin's hand. Okay, it's hard with the bright lights. And we'll see how the combatants do to change our theory on this. Dr. Melvin, I'd like to invite you up to the podium. Thank you.
Thank you, Dr. Marks and Dr. Young-Fadek. It's a great opportunity to be here, and I really appreciate giving one of the easiest topics to defend and present here today. Obviously, I respect all those people who have raised their hands, and so they understand that this is obviously a foregone conclusion. Notes has been a nice ride, and it's an interesting topic. Let's look at where we are with notes now. It's not widely practiced outside of a few places outside of the U.S. And after really more than a decade of work, there's no data to exist to suggest superiority and little data for equivalence. There's even a very minimal current investment in enabling technology. Our business partners are very smart, as is many of the surgeons, and so they've stopped investing in the technology. It remains a neat idea that I'm sure Dr. Rattner can play around with from time to time and is an interesting research tool, but it's really time to move on. So I thought we'd talk about something different. I respect SAGES a lot, and having the honor of being the president, I respect the members of SAGES and their collective intelligence. So let's talk about group intelligence. Group intelligence describes how, under the best circumstances, large numbers of people can look at this data, simultaneously converge on similar points of knowledge. It's really a science that describes how buying decisions are made for consumer products, but it certainly can be extrapolated to science and patient care. The Wisdom of Crowds is the book that really described this. He claimed that group intelligence requires independent thought, and group intelligence connotes a more rational decision processes. Smart decision-making processes are based on knowledge and understanding, and therefore are actually collectively better than perhaps one single individual from Boston who may be misguided. 6,000 SAGES members can't be wrong. Notes is not widely used. It should be put to rest. Now, that's not saying that I don't think the future of surgery is anything different than minimally invasive surgery. And there's a lot of different topics that we can talk about. Notes is not a new idea. It's not even a new topic. It's not even a clinical tool. But I think it's important that we realize what we're talking about, because I would guess that in order to suggest that notes is a good idea, Dr. Rattner may talk about things that have nothing to do with notes, things like natural orifice surgery, endoscopy, which we all are familiar with, which isn't a big controversy, hybrid surgery, single port surgery, and a variety of other different kind of synonyms and confusing monikers that are applied to a variety of different technology that may or may not be relevant to notes. We do know that notes, when described, had a variety of different access routes. This is for historical note, colonic and transgastric. Transvaginal surgery still exists in certain pockets of the world, as well as the possibility of transvesicular procedures. Let's look back where we've been. Notes was a clinical idea in the early 2000s. NOSCAR was founded as a cooperative agent between SAGES and ASGE in 2005. Since then, millions and millions of dollars have been spent on research. And if you remember my first slide, there is no significant data, but I'll show you the data that does exist. There are very few new devices. We continue to use old devices for the majority of surgical procedures that we have, and there's very little objective data. Let's look at the clinical data, because this may be the first opportunity and probably the last opportunity you have to see any data surrounding this. Transgastric surgery were done. So I was fortunate enough to be with the team that did hundreds and hundreds of transgastric surgery for a variety of different procedures. There's obviously no need for further research, and that's a dead sport. Transvaginal approaches has a potential clinical use. It's an active area of investigation. Some markets have adoption, as well as the transanal route, which is a current area of development, which may actually be something that we can talk about, and certainly an area of specialty of Dr. Rattner, finding objects there. Single incision, here's some data. So this is probably one of a bigger review paper, a real trial, comparing transvaginal and conventional laparoscopic techniques. And here are the strong conclusions. The techniques are possible. Strong conclusion. Conventional laparoscopy was faster than newer techniques, another strong conclusion, and any technique was acceptable. The data continues. Let's look at postoperative pain. Obviously a clear advantage for node surgery. There'll be no pain. So almost 100 patients were randomized. The data was that the OR time was longer. And despite the nice assumption that there's no pain, you can't prove that objectively. There's little data to suggest that there's no objective difference. Patients, as it turned out, were generally pleased with their operations. And when asked whether they would recommend it, most found it would be appropriate to recommend the technique that they chose. It's no worse than standard surgery. I'll concede that point, Dr. Rattner. But there are a lot of barriers to adoption. It's a steep learning curve. It's difficult to learn, it's difficult to use techniques, and using instruments that we don't reliably do what we need them to do. There is a surgeon comfort, and not physical comfort, but a clear mental comfort that we have in providing the best care to our patients. It's very difficult to change our risk benefits for the patients. It's an ethical dilemma, in fact, without any data. Therefore, smart surgeons collectively choose superior techniques, as you just demonstrated a few minutes ago, by the educated ones who voted. So what about instrumentation? We're using old technology. We know that. We use old endoscopes. There are new ideas that are not largely, that have been shelved, but aren't able to be used. There's little clinical work on new instrumentation. And this really has slowed our adoption and our ability to use these, to do these new procedures without this clinical instrumentation. Devices like this were talked about and are not available. What about ethical standards? It is reasonable to advance science through through human experimentation. No choice. Informed choice, informed consent, minimal risk with appropriate investigators, peer review publication, things like the NOSCAR registry for human work, appropriate. It's reasonable to apply new procedures and experimental data for patients. But experimentation without the expectation of success is perhaps not appropriate and perhaps should not be considered. There are other barriers that we all have to be realistic about. No one can approach their hospital for equipment, for time, or any other reason without having the dollar signs in the back of the mind, because we need to be able to provide patient care to large numbers of patients in a value-based analysis. So if you spend 4 hours to do a cholecystectomy with excellent cosmetic results and minimal pain, that doesn't really help the other 3 patients who aren't going to get treated that day, nor necessarily help your bottom line when it comes down to demonstrating your work effort. Cost, besides increased time, this perhaps in retrospect will look like another industry-led initiative to increase market share and to increase notoriety and profit margin rather than just patient care. So new technology in surgery needs careful investigation. Improved patient care is certainly the goal. Our instrumentation is lacking. Spin-offs may be the benefits, and that's maybe what we'll hear about later, and some of those benefits have been realized. It's a reasonable area to initiate research, and human work may continue to be acceptable with the rigorous standards and review. And that was a slide that was written in 2005 and is still relevant today, almost a decade later. This is not the future. Notes is dead. Thank you.
Please take a seat, Dr. Melvin. Dr. Rattner, I'd like to invite you up to the podium now, please.
Well, I have to confess that Dr. Melvin and I are close friends, and he's done me a great favor today with this incredibly lame presentation. So I'm going to convince you that the day is dawning for notes. These are my disclosures. Now, first of all, I want to take a little swipe at Jeff and Tonya, who, although they've done a fantastic job with this year's program, have never heard Santayana's quote that those who fail to study history are doomed to repeat it. And the first presidential debate ever to occur happened in 2008 in Philadelphia, where I was pitted against another good friend of mine, Dan DeZiel, which the notes is nuts or notes is dead debate occurred, and I hope I don't have to remind you the outcome of that debate. So when I got this invitation 6 years later, I went and I got a picture of Scott when he had all of his hair, and this was his reaction as well as mine to having to rediscuss this topic. So at the time of that last debate in 2008, the human procedures were transvaginal and transgastric cholecystectomy, and I will concede transgastric cholecystectomy is dead. However, transvaginal is not. People continue to do transvaginal appendectomies, and in fact, in this month's Annals of Surgery, there's an article from the Yale group describing their results with transgastric and transvaginal appendectomy, certainly something that is current and not in the past. Now, there was another event that happened in 2008, the year of that last presidential debate on this subject, but it wasn't reported at the time, and that was the first poem carried out by Haro Inoue. And I think it's fair to say in 2008, the States of Notes was not dissimilar to this little seedling held in a few caring hands. I will concede that the interval between the last debate and this, there were few dark storm clouds on the horizon, not the least of which was the FDA's intercession in the prevention of the Notes toolkit, which Dr. Melvin kindly showed you some of the elements. But while these storm clouds were gathering, work was ongoing. The German registry study, over 650 Notes cholecystectomies, was accumulated and published. And by the way, so in spite of the fact you said there's no data, I'm going to actually show you real data. In fact, there's more data in this slide than there was on your whole talk. NOSCAR's randomized controlled trial was completed during this period of time, and we're anxiously awaiting the publication of that. There was ongoing innovation. There's a dedicated community of investigators, both in Europe and the US, who continue to meet on an annual basis, share information, and continue to make slow and steady progress. And I would submit to you that for sure I can say that in 2014, and you acknowledge this as well, that Notes is feasible, and I'd also say that Notes is safe. Now, I don't know about you, but I've been at this meeting for the last couple days, and I've been astonished by how many presentations I've seen about Notes. And it's hard for me to understand how Notes is dead when there can be so many presentations. In fact, at this meeting, there's 6 original presentations, and in fact, an entire session devoted to poem. And there were 57 publications about poem in the last 3 years. Now, thousands of these have been performed worldwide since Dr. Inoue did the first one in 2008, and I suspect that once you come to the enlightened East Coast, you will find that many of your patients actually use the internet and will be asking you for poems rather than for a Heller myotomy. Furthermore, this procedure offers advantages for things you can't get at with a laparoscopic Heller myotomy, things like esophageal spasm or redo myotomies. Or how about the morbidly obese patient? And it's true, whether they get obese after their bypass or before, these patients are out there, and this technique has a unique advantage over lap Heller. Not only do we have poem, but we're evolving into poet, per oral endoscopic full thickness resections. And the people that are leading the charge are NOTES people, Haru Inoue, Sergei Kantsevoy. And yesterday, Dr. Kantsevoy showed us full thickness endoscopic gastric resection and colonic resection. And although you say that there's no new tool development, the Apollo overstitch, which was really a prototype when we started, is now commercially available, being sewn, and proving to be an ideal instrument for full thickness endoluminal resection. And oh, you forgot to mention another project you were involved with, another NOTES project. I believe this is called transoral incisionless fundoplication. And I think that was billed as a NOTES procedure, if I remember correctly. And there's several thousands of these that have been done in the United States as well. So hardly dead. Perhaps hard to get paid for, but not dead. Well, let's shift to the other end of the GI tract. If NOTES is dead, and it's time to declare the death of it, why are so many people writing papers? Look at all these publications in the last 3 years about transanal human NOTES. Here's just some of the titles, and you can see that this is gathering steam. It's an area of great topic. This baby has been born. Antonio Lacey, 90 transanal colectomies for benign disease, 110 proctectomies for rectal cancer. At this meeting alone, there are 10 original presentations on transanal NOTES and another clinical symposium devoted entirely to this. Now, for those of you who raised your hands and want to declare the death of NOTES, I suggest you go home from the meeting a day or two early. This transanal NOTES thing has really got legs. We're past phase 1 now. We're ready to go to phase 2 clinical trials, nationwide, multi-center. And there's more coming. This is just the beginning. People are talking about doing pyloromyotomies. We have endoluminal gastric plication. We have magnetic anastomosis. We have the full thickness resections I've showed you. We're branching out from the GI tract. We're doing transoral skull-based surgery. That's NOTES. So I wanted to show you one of your favorite friends. I know how you feel about politics. And so I'm going to show you, you're even going to have to agree with our president that big changes are underway. NOTES is an evolutionary process. It was never meant to be the killer app. The environment around us is changing. Tool development is occurring. We even have cultural changes mandated by the American Board of Surgery, where flexible endoscopy is being emphasized. And one of the things that that's going to do is make endoluminal surgery and transluminal surgery a part of a surgeon's everyday practice. And lastly, the ACO model, it'll be easy to get paid. You're going to get paid for taking care of a population of patients, no matter how you do the operation or how many operations you do. And this will actually be an enabler for NOTES and some of these techniques which are a little bit out there on the edge. So, my friend, I hate to tell you, growth takes time, and patients will be rewarded. Don't discount the impact of new technology. I can't believe you were president of SAGES and we're such a naysayer up here today. And 25 years ago, surgeons are going to do procedures that don't even exist today. We know they're going to be multidisciplinary. We know they're going to be multimodality. We know they're going to be image-guided. We know we're going to replace organs with tissue-engineered organs. And that today's fatal illnesses are just chronic diseases of tomorrow. Think about AIDS. Think about metastatic colon cancer. There's a growing emphasis on endoscopy and patient desire. Make NOTES a sure bet to be present in the future. Thank you.
Dr. Rattner, you remain up at the podium. Rebuttal comes from from the second speaker.
How can I rebut when there's nothing to say?
But you've seen his lecture, that's why you get to rebut based on
Oh,
what he's done.
oh, okay. Well, I do have a few other slides, Scott. And I have to quote a famous Bostonian here, courtesy of my friend from Chicago, Dr. DeZiel. And that's, facts are stubborn things, and whatever may be our wishes or our inclinations or the dictates of our passions, they can't alter the state of facts and evidence, which I believe I probably had 10 times more facts in mine than you had in your presentation. So get with it, believe it. Notes is here to stay.
Could I have my slides back, please? Dave, thanks a lot for that recap of the 2008 debate. I see you took off your old slides and dusted them back off. Actually, you gave the co-moderators here very little credit. They gave you an opportunity. They knew that you had done this debate before, and this was really an opportunity to redeem yourself, and they're disappointed you failed again. I'll concede that cases have been completed, that there are registries that show, yes, you can do it. I will not concede the fact that there's any data to suggest that it's a superior performance of operations. Are my slides back up? You spent a fair amount of your time talking about some interesting endoscopic therapeutic procedures, including TIF, POEM, and some other interesting endoscopic procedures. Let me walk you back real quick. Notes, natural orifice, translumenal endoscopic surgery. None of those things that you tried to hide the data with the smoke screen actually are NOTES procedures. They're in fact endoluminal therapeutic procedures, which I do think have an important role in the care of patients with gastrointestinal disease. So those are certainly important facts that you missed out on. In general, the natural orifice surgery does exist. It continues to be an area of development. However, for the most part, the clinical practicing surgeons don't go home early. Stay here, enjoy the weekend, enjoy the meeting, educate yourself. There's no reason to go home and believe what you've heard. And collectively, as a group, your wisdom will outshine. What's that? Okay. Can I see my slides? Or? So, as I said, it's not relevant to discussion, to this discussion, but thanks for that comment. And okay, so as it's not going to show up. So as I have pointed out, I think that we will enjoy a future of minimally invasive surgery using a variety of flexible endoscopic techniques, as you suggested. And in the future, there may be some notes, but as of today, notes is not an active clinical process. Thank you.
Well, that was a great start to our presidential debate. Are there any questions from the audience for our two combatants before we re-vote? So, anyone coming to the microphone? Maybe not. All right, so I'm going to ask one for each of them. All right, so Dr. Rattner, the letters may be changed, and I think Dr. Melvin brings up the point of this translumenal, and maybe you can describe for us why the letters aren't as important as the concepts in terms of how we got to POEM and some of these other concepts.
So, debate aside, I think everyone knew from the beginning that this was surgery, that it was done via endoluminal access, complex endoluminal surgery. And as originally conceived by Tony Kalu was transgastric, but I mean that became pretty clear from the outset that transgastric may not be the most accessible. And in fact, Chris Thompson and I knew in the lab in 2003 or 2004 that going transrectally was much better than transgastric. But I think the letters have changed a little bit, but I do think we will get to truly transluminal endoscopic surgery for gastric resections, for colonic resections. The monos or transanal notes resection, I mean, that's transluminal resection. So I think we're going to get there. I think the technology is coming along. I think that we had a terrible recession that intervened in 2008 to 2011 and really threw cold water on biotech investment. We've had some issues with getting things through the FDA as well. In spite of all that, if you look at what's being presented at this meeting now, it's really remarkable.
Great. So, Dr. Melvin, then I'll ask you a question. I don't see anyone out in the audience at the microphones. So, if you look at surgery for the last 30 years, we keep losing cases and cases and cases to flexible endoscopy. And if history is supposed to repeat itself and continue, why don't you actually believe that the things that Dr. Rattner is describing are going to gain legs and actually be here in 5 to 10 years?
So I think that what you pointed out is only partially true. We haven't really lost procedures. We've just changed procedures. Open splenectomy, open cholecystectomy are gone. We've not lost those procedures. I think we've lost open Heller, and we've lost laparoscopic Heller because we've come up with a better way to do it. We haven't lost it. We've just found better ways to do it, better ways to take care of our patients. Dr. Rattner had a slide that in 25 years, surgery will look remarkably different. I agree with that. You'll be long retired by then, but for us younger surgeons, I think the time frame is even shorter. Within the next decade, I think that we have the opportunity to significantly change the way that we treat gastrointestinal disease, specifically using flexible endoscopic techniques. The barriers that do exist are only part by the FDA, but also by our payers. I think it's important as a society and as individuals that we continue to be advocates for our patients and for new technology, because insurance carriers who deny payment based on whatever their rationalization is not always in the best interest of our patients. So we need to continue to beat that drum and work towards acquiring payment methodology for new technology. The FDA has streamlined and made their process much more transparent and done a nice job. The biggest barrier to adoption now will be the payer mix and commercial payers who are protecting themselves rather than our patients.
Hey, we finally agree on something.
Okay. I think Tonia's got one question.
David, a question for you. You'd mentioned that during the meeting you had seen endoscopic performance of full thickness resection of part of the gastric wall, and I can potentially see the applications of that, but part of the colon wall, I'm at a bit of a loss as to what that would apply to, because a polyp doesn't need full thickness resection, and a cancer needs a lymphadenectomy or formal resection to go with it.
So I suppose if you had carcinoma in situ would be a flat polyp. Not sure carcinoma in situ would be a good example.
Okay. We don't want to go too much in that because that's kind of our topic that we're going to be leading into. But
Yeah,
that's
right,
a great
right.
segue. All right. Any other thoughts? Any questions? Is there someone at the microphone? I don't believe so. All right. So after our wonderful two incredibly esteemed presidents have given us these talks, I want to take another vote from our very intelligent SAGES audience. So here it is again. Be it resolved that it is the time to declare the death of notes. All in favor, please raise your hands.
Well, I can count them on the fingers of my one hand.
You know what? I think we did okay here. All right. Thank you very much.